Okay, friends, I think we're going to get started. Um, so I'm getting some message. Oh, Joyce told all of us that she's supporting someone in labor, not just me. So you all see that. I am going to mute everybody for the time being, just because we can hear you typing and we can hear your beautiful families and your dogs and your babies. So we're just going to mute you for now, if that's okay. This presentation is being recorded and we will be putting it up on our YouTube channel. We will be making sure that there is a link to that available at the NYC Homebirth Midwives Facebook page and also at nyhomebirth.com. So you'll be able to access that. And I just want to take this moment. I'm also hosting. My name is Tanya Wills. I see lots of people that I know here, but also many that I don't. And I'm a midwife. I'm a home birth midwife and a childbirth educator and lots of other things. I like long walks on the beach. And we're very excited. The New York City Homebirth Collective, of which I am a member, is a collective of home birth midwives that practice specifically in New York City. And we've been working together as a group for quite a while now. And of course, now there's plenty of attention that's being paid to home birth. So we're very glad to have this opportunity to talk directly with all of you about home birth so we can answer your questions about home birth. We can hopefully demystify the process of having a home birth and talk a little bit about home birth in the setting that we're in now. Specifically, people have a lot of questions because of COVID-19. I don't need to tell you the only thing that you read about right now. So that's what that is. Some of you have gone ahead and emailed me questions ahead of time, and we will be going through them. But for the time being, what I'd like to do, if it's okay with the midwives who are here, hopefully you all know how to unmute yourselves, but I thought it might be interesting for each midwife who's here from our organization to introduce themselves, tell us a little bit about your practice, and that would be great. Maybe the name of your practice, and just kind of wave to everybody and tell them that you're here, because I know you may think that you're here as a guest, but you're not. So you're part of the panel. So is there a midwife here? Maybe Nuranisa, do you want to go first and introduce yourself?
Sure. Hi, everybody. My name is Nuranisa. My practice is Noor Midwifery. I practice mostly in Queens, Manhattan, Bronx, and Westchester. That is sort of the area that I serve. Yeah, and I'm here to help Tanya and Kim and whoever else is here from our group answer any questions you guys have.
Thank you, Nuranisa, Noonie, we all call her. Kim, are you here? Do you want to go next and introduce yourself?
Hi, everyone. I'm Kim. I work in all 5 boroughs with my partner, Catherine. She can't be here today because she's running another Zoom group. And I'm been in practice about 10 years now. And yeah, I'm also here, obviously, for, we're all here for this reason. Everything is so uncertain. And I hope that all of us can pitch in and help answer as many questions as possible for you guys.
Thank you, Kim. Shauna, I think I saw that you're here. You have to introduce yourself.
Okay. Hello. Hi, everyone. I'm Shauna King. My practice is called Amai Midwifery, and I serve all 5 boroughs doing home births. Been a midwife since 2002 and have recently made the transition to doing births at home. And I'm happy to be here and to help answer any questions.
We're glad you're here. I also see that Martine is here. Martine, do you want to introduce yourself?
I am Martine Jean-Baptiste. I've been a midwife since 2000, home birth midwife 2002 to 2019, and just hung up my birthing gloves this summer after 17 amazing years of doing home births in the 5 boroughs of New York City. And I'm still very much part of the home birth community.
Yes, and Martine is the resident, well-rested midwife because she hung up her gloves. So if she has slept maybe many nights in a row. So we're glad to have you as the voice of reason, unexhausted person. And I'm Tanya Wills, and I practice with Robina Khalid. We are Small Things Grow Midwifery, and we help people in the 5 boroughs. In the 5 boroughs. So I think what we're going to do is just go ahead and get started. And the first thing I just wanted to share with everybody here is just to mention that, you know, a big reason why we're holding this webinar today is because any midwife that you just heard from, our phones have been really, really inundated since the COVID-19 pandemic came to New York City. And people have called us with many questions, some that we have never received before. So we realized that it was a great opportunity to provide education to the public and to speak with you a little bit about, you know, maybe you're considering home birth if you are pregnant or for a future baby, or maybe you're planning a birth in the hospital and you want to hear from us. You want to know what we think about all of this. We're very, very happy to share that with you tonight and hopefully have a really nice, honest conversation. So what I'm going to do, if it's okay, is just start with the midwives. And I thought it might be interesting for us to spend about 10 minutes just hearing each of us speak for a couple of minutes about who is right for home birth and what we see as somebody who would be a candidate for home birth. Who wants to unmute and go first? I can call on people if I must.
I can do it.
Thanks, Kim.
I'm sure other midwives have a lot to pitch in, and we have a lot of the same thoughts, but I thought I would talk about something that may be a little unique, that which is what low risk is all about. Interestingly, I got we're getting a lot of emails and calls, and they often say they are low risk, and I've always wanted to answer that question of what is low risk, because low risk is such a wide, almost subjective spectrum, other than some very specific conditions, right? Preeclampsia, which you all, I'm sure, know of. Something, cholestasis that you can get at the end of pregnancy, and that is, that's high risk. But and there are a few more, but not that many. Like, for instance, a serious heart condition and asthma, that's, as you enter into care, that's, an uncontrolled asthma. Those are high risk pregnancies, very specifically, without question. The other kind of risk factors are really, for us individually, we try to use common sense as to what that is about. For example, if you had a thyroid issue, right, and you're taking Synthroid or anything, as long as your thyroid levels are normal, generally you're considered like anyone else. So most people are being seen by an endocrinologist, and it doesn't change anything. It's not, it doesn't have anything to do with, whatever's going to happen to them. So we consider that low risk. So these are the things that usually we can, it's something that you need to ask us, or you can talk with us first to determine whether or not you're high risk or low risk. So there are a lot of questions that we can answer, and often that, for example, another example, the age factor, 35 and above being high risk. Well, the average age of our clients, I think, is somewhere between 35 and 40. So, we don't consider that high risk. We're looking at the person, we're looking at the background, we're looking at their diet, we're looking at their weight. Absolutely, we are. I mean, I don't want to kid around. So, weight depending can be an issue either way. you know, and then we're not saying yes or no either. We kind of have a spectrum, like is this low, is this high? And the key is educating the women about what they need to do, what this means when they have a certain, you know, they present with a certain thing, what this means, and whether or not what are their concerns addressed as far as the safety. And then very important, what's their decision? Because we support your decision to go ahead with something that, you know, is to other people maybe iffy, but you might feel safe after talking to us that this can be done at home without worry. So that's my long way of saying, just talking about risk factors. And now I've talked too much. I'm gonna let my other colleagues say something as well.
Yeah, that's a great point, Kim. And we get a lot of questions about risk factors, specifically people over 35 very frequently are having babies. They're having babies in many settings, and home is certainly one of them. It depends on a whole package. I don't know, Martine or Noonie or Shauna, do you want to say something about other risk factors? Martine? Yeah.
Yeah, I said there, this kind of goes twofold. There's physical risk factors and mental risk factors. So when you're talking about screening, it goes from the time that you receive a phone call that you're, you know, figuring out if someone's appropriate for care. So I hold on. I'm trying to do two screens at the same time. I did sometimes I do talks about what's needed or what's the general criteria. And I had handouts I would give to people when they were seeking to have home birth services. So I'm just gonna read it down really, really fast. So healthy physically and mentally, which does not mean if you have a history of depression that you cannot have a home birth, but that just means that you're in a good place and you do have a therapist, or you're working through issues, because pregnancy, sometimes if you didn't have issues, or sometimes you wind up with some issues that you need to address also. But and a well-nourished woman with adequate social supports before, during, and after birth is really important criteria to have a home birth. The primary participant is mature enough to accept the responsibility of any birth outcome for them or for their baby. Commitment to maintaining a positive emotional environment for best outcomes in pregnancy and birth and postpartum. We highly encourage childbirth preparation. And, you know, if you do have clients that can't afford to take classes, there are other creative ways that you can have childbirth education. Although our visits tend to be, you know, about an hour for revisits for most of us. So there's lots of education that goes on there. But sometimes, having been a childbirth educator since a long time, we'll say, sometimes it's very helpful to get information from someone that's not your primary provider also, because people will hear but so much information from one source. So we highly encourage people to take childbirth classes, which included breastfeeding and newborn care. And preparing the people that they want present at their birth to be able to be present at their birth, or recognizing what their strengths or weaknesses are, because some people feel obliged to have certain people at their birth, even though it might not be the optimal person, but just having that outlined ahead of time. So if it's your mother and she wanted to be there, but she didn't really want to be there, then you can incorporate what she can do, or, you know, you could start talking about that ahead of time. And if it's somebody that's transferring in, complete records. And it's really important for people to review records completely before you totally accept someone into your into your practice, because in the 17 years, you'll be surprised at what happens when, you know, people say, I've had no problems, everything's fine. And you get like this record, like ours are like this big, this big, you look through it, it's like, oh, she has heart valve replacement 5 times, and she had this. But my heart is good now. So, you know, little surprises when you actually see records versus what people tell you. And also we require that they have some kind of pediatric arrangement by the time they're term, so that they do have a place to go. Although midwives can and do take care of the newborns, we highly encourage them to have, you know, nurse practitioner, a family practice doc, or a pediatrician, so that they can see also, or in case of emergencies. And really discussing from that first phone call, like I said, about transport, and if you needed to be transferred, what happens and what does that look like? And then of course you talk about that throughout the pregnancy and birth. And then there's some other real medical contraindications to having a home birth. And that is totally all bullet pointed and written out to and gone over with clients so that they really understand. Like I think Kim had mentioned maybe diabetes in and of itself is not a risk factor out, but a well-controlled person with no medication on diet, with also seeing a nutritionist during her care, can have a home birth. So it's things like that. So sometimes I've had people that will come and say, someone told me that I could do this or that. Sometimes when you're not the actual medical provider, for lack of a better word, people aren't always disclosing the correct information or not interpreting what they were told correctly. So sometimes I would, because I was a labor support person before I was a midwife, before they used the word doula. So sometimes I would find that they didn't disclose everything to me, or they didn't understand it correctly, because I had been a nurse too. And sometimes when people tell me things, I was like, that's like not humanly possible. Like, I don't really know what they're talking about. And so I always say, as for doulas and things, kind of take some, you have to believe your clients too, but just also know that you may not have all the information that they're telling you.
Thank you, Martine. That's incredibly informative. And I agree with everything that you guys said. One contraindication in my practice to home birth is if your partner is not on board with having a home birth. You can't even get in the room to talk to me if your partner's not on board. And I'm seeing lots of nods from my colleagues. So in case you're wondering if any of us can sit down with your partner and convince them that a home birth is right for you, the answer is no, we can't. We can provide you with lots of information about home birth that you can present to your partner, and you guys can definitely take time together to learn about it and see if it's right for you. But it's not safe for us to be home if one of the people there doesn't feel safe. So we can't practice safely in that environment. So with that being said, Noonie had a great idea, and I thought it was a terrific idea for us to just take a quick poll to see who actually is here with us. I want to make sure there's nobody else trying to get in the room. Okay, we do have 62 people here. I'm very excited about that. If you hover your mouse over your little face, if you're on a laptop or a desktop, you'll see the ability to raise your hand if you choose the three dots. So if you're here right now and you are here because you are pregnant, could you raise your hand? Oh, you're raising real hands. Okay, good. You can also raise virtual hands. Maybe it's mostly real hands being raised. Hold on. Raise them again.
Yeah, I don't see that feature.
You don't? A couple people did it.
I saw people, maybe I'm gonna unmute myself. I mean,
you can unmute, Noonie, just because you're a grandma. It's fine.
It's Lisa.
If it's not on,
Hi, Lisa.
Hi. It should be on the right hand. It should be on the right hand side under the list of everyone's names. You'll see something about raise hands. Looks like this.
I didn't see it under the three dots. I saw it over on the participants window. So if you click on participants, you might find it.
Thank you, Lisa and Martine. So I gave you the wrong information. Okay, so we have 1, 2, 3, 4, 5, 6, 7, 8. You can see, right? Can you guys see the participants? You can see who's here, right? Yeah, so you can see, and a couple people just sort of raised their hand as well. So great, so clear hands. You can lower your hand now. Let's see if you can, I think it's probably also there. So now raise your hand if you're here because you are not pregnant, but you're just an interested citizen who is not a birth worker. So maybe you have a partner who's pregnant, or you may become pregnant, you may decide to use your uterus at some point in your free life. Okay, a few concerned citizens, welcome. We're glad you're here. Wonderful, wonderful. And you can lower your hands. And if you are here because you are a doula or a lactation consultant or a midwifery student or a childbirth educator, raise your hand if you will. We just like to know who's here. Okay, a lot of friends here to gather information to pass on to their clients is what I think is going on here. So great. And there are other people here too. And I wonder if you're not a concerned citizen and you're not pregnant and you're not a birth worker. I don't know what else you could be, but that's fine. Thanks. You can lower your hands. Wonderful. And we do have a bunch of people that wrote in with questions before everything started tonight. So we'll make sure that we get to those. But now that we've talked a little bit about risk, I thought it might be a good idea for maybe, I don't know, Noonie or Shauna, you could talk a little bit. I think everybody who wrote in had a question about home birth and safety. And I think that this is a question that we get basically in every single interview that we have, is people ask us, is home birth safe? I asked my doctor and he said no. So, so do one of you guys want to comment on that?
Yeah, I'll go first. I wanted to just add on to sort of what Kim and Martine were saying. I'm in total agreement with what both of you guys said. I think one of the most interesting things, though, about coming into home birth is understanding that the culture that exists in the system doesn't work, and you're looking for something better for yourself and for your family, and for more options for yourself. So it's a culture which I think people don't even know that an option exists for them. But I think the culture is really what needs to change, and I think we're in a time that is really recognizing that. But when people ask, about if home birth is safe, you sort of go back and, for me, I'm sort of like, well, yes, of course it's safe. Do I look like a crazy person? That's usually the card that I play with my friends who ask me this. But, we go back to talking about a healthy body and a healthy baby, a healthy pregnancy, and sort of thinking about pregnancy and the body and the relationship between the pregnant person and the baby. And this is a perfect working machine, right? And in home birth and as midwives, we sort of just guide it and we keep it nice and oiled so that it can sort of continue to do what it needs to do. And that goes on into labor and birth and the postpartum period. And we sort of just are there for if things start to go off track, right? But if we believe that our heart beats normally and our lungs, we breathe without knowing, and we do all the things that we need to do in our body, if you can sort of start to think about birth in that sense, you sort of have a better understanding of how your body works, and this is really what makes birth safe. So that, for me, and I think it also depends on who I'm speaking to. If it's somebody from a medical background and you can really get into the nitty-gritty of physiological birth, then that's sort of where I gear my conversation to really help them understand in their own language why birth is safe. And then for the people who really truly believe in the numbers and the studies, there are studies out there that that we can present to people and explain why birth is as safe as it is, especially in this country as well.
Yeah, you can find some of those studies are listed at nyhomebirth.com under the resources. So if you are a person who enjoys reading studies or knows somebody who enjoys that, they are listed there. Sorry, I cut you off. No,
yeah. Yeah, I think mostly when people ask me that question, I sort of try to figure out who they are as a person, and then explain to them the safety of birth in a way that they can understand. Because I think if I start rattling off, the numbers of all of our safety studies, that's really not going to sink into somebody's, and explaining what we bring to the birth, and not just at the time of birth, that when people come into our practices very early on, or even in the middle of pregnancy, we have time, all of this time that we dedicate to building a relationship. And the base of a strong relationship is trust, right? And we know this from all of the trusting relationships that we have. And we're sort of trained in this culture to trust the medical system and to trust an institution, right? And we believe that an institution with a fancy logo is the way to really go. But now we know that these fancy logos and these fancy hospitals are the ones that are not doing well by women. And that's really where the problem is. So I think once we really gain that trust, we can talk about the nitty gritty, and we try to make sure that our clients feel comfortable asking us even the hard questions about what happens if a baby comes out and there's a cord around the neck, and that's the hardest question anybody ever asks. And
also
I think
the question everybody always asks.
Yes. And the question where you're like, you just take it off, or you just deliver the baby through it, or you just say, oh, that's a cute thing around the baby's neck. But it is a really common question, but we can answer that if people really want to get into what happens when there's a cord around the neck. But I think it's really important to answer the scary questions, like what happens in case of a transfer? What happens if the baby doesn't breathe? What happens if I bleed after I have the baby? And we make plans to transfer people. That's the responsible thing for us to do, because it needs to be done. But despite what some of these articles have been saying, if you look at our statistics, we have very, very low transfer rates for the main reason of really working closely with these people and making sure that their diets are on point, and that they're exercising, and they are trusting their bodies and their partners and their midwives and their birth team. So it's a lot of work that goes into it, but when it works, it works.
Thanks, Noonie. Shauna, would you be willing to talk a little bit about the types of things that you bring to a birth, and what types of situations can be handled quite nicely and efficiently at home, and what types of things would somebody need to transfer to the hospital for?
It's so funny because I was just going through my birth bag right before this webinar, because I was just making sure I had everything in place and everything was ready to go, because I have somebody whose due date is tomorrow. We bring, and I say we loosely because I think that there's some variations to what are in the bags, but I think for the most part, and a lot of people are really curious about what we bring. And I bring something that's a suitcase that's rolling, so it's a lot of stuff. And I know some midwives, they bring like a really small little bag and bring less than I do. But so we bring some emergency equipment with us. I think most midwives bring oxygen with them. They bring a bag and mask for resuscitating a baby. We bring some emergency medications for hemorrhaging. Most of us bring Pitocin, maybe another medication called misoprostol, maybe one called Methergen. Some of us even bring some herbal tinctures with us. Many of us use herbal medicines for some labor complications, and so we may bring those. What else was in my bag tonight? If there is a laceration, we may need to bring suturing material and equipment for suturing and for cutting the umbilical cord. We also bring IV fluids if needed. Yeah, so those are some of the things. I probably left some things out, but
they're in there.
Those are some of the major things that we bring. And then, I bring a heating pad and a TENS machine and a tennis ball and a Doppler for listening to the baby's heartbeat. I think most of us use Doppler. We do intermittent monitoring. And there's a protocol for the intermittent monitoring when you're in labor that most of us follow for listening to the baby. So that's really how we are assessing the baby's well-being while you're in labor, is listening to the heartbeat, usually every half an hour when you're in labor. And then once you get to pushing, we're listening a little bit closer. So yeah, did I forget something?
Probably there's something else in there, I'm sure.
There's always something else.
Yeah, there's vitamin K in there.
Oh,
there's
right,
antibiotics in there.
Exactly.
There's syringes, lots of stuff,
Yeah.
That most of the time we don't need to use, but we mostly take it out, set it up, and then put it away. But if we need it, we use it. And if somebody has a hemorrhage, we people say, what do you do if I hemorrhage? And the answer is, I treat it. I'm not bringing you anywhere. I'm going to work on this right now. So we bring things like that. And reasons for transfers, tend to be in three categories. One category would be the status of your pregnancy changes somewhere in the middle of the pregnancy. So an example of that would be you go for a 20-week sonogram, an anatomy scan, and we find out that your baby has a heart defect. And it is determined by all of us together that the hospital would be the most appropriate setting for your birth. So that's like one scenario, and you can imagine things like that. Another reason would be if you get preeclampsia or cholestasis. These kinds of things are a transfer to the hospital for an induction. And then in labor, the most common reason that people transfer is basically exhaustion. So you've been laboring for many, many days sometimes, certainly hours, definitely sometimes days, and it's definitely individual depending on the person that we are caring for, because different people reach their limits at different times. But many people, if they transport, it is for pain relief after quite a while, so they can rest. Rarely it's because we don't like what we're seeing in the baby's heartbeat and things are getting a little bit funky, and so we sort of try to resolve it right there at home. And if we can't, then we transfer you to the hospital, because that's going to be a better place to birth the baby. Generally speaking, babies can tolerate some amount of distress, essentially. I mean, there's some amount of this that is okay, which is why if you live near a hospital, which everybody in New York City does, as long as you have an attentive midwife, we're pretty good at sort of seeing 10 steps ahead of the game and making decisions quickly. Even without all of that, the transfer rates that we have are usually below 10%, and overwhelmingly, most of those transfers are going to be people having their first babies. There's some article that came out saying it was like 50% or something. I don't know. That's like a non-source. That's like, she like heard that from somebody, I don't know who, that's not a thing. So I thought that I would add that. So if it's okay Kim, you want to say something?
Yes.
Yeah.
I also tell people that not all transfers for mommy. Some transfers happen after the birth.
Oh, yes. Go ahead.
And the birth transfers, in almost every case that I've done, and it's just sometimes this is a game of numbers, and you never know. You always have to be prepared. But as far as what I've experienced, the transfers has been a couple of hours after the birth. So because it's scary. It is scary for you to think about what would happen to the baby after baby's born. So because most of us are, taught culturally that there is this frenzy when the baby's born, and like there has to be 10 people in scrubs jumping on the baby. And the home birth, the way that we assess whether the baby's doing okay is to watch very closely for what we call like breathing tone. And so that, I think it's really important to talk to people who most of my questions, most of the people who ask me are worried about that. And I'm very honest with them. I say, yes, in a situation where the baby needs help in a way that we cannot handle, which is this whole, we do bagging, we bring ambu bags, but the resuscitation is a whole spectrum. If there's a situation where we cannot handle in long term, meaning that, we need a whole team, the hospital is actually a better place. I'm very honest with people about that. So then why would you ever think about a home birth? And the reason is that it's not totally unpredictable. So we're not, if you have a heart condition, we would have transferred you out before that. So, because babies with heart conditions need this kind of work. And if babies were compromised in labor, we would have transferred so that, when the baby's born, the baby would have pediatricians available. So what ends up happening with our babies when we've transferred is that, the baby needs some time, the lungs are not clear. And I believe Martina and I have been to a birth where everything looks so good to everybody. The baby's calm, breastfeeding, Do you remember that, Martine? But we were seeing the little flare, so we can see
Very
things.
well, thank you.
Yeah. We can see that the nostrils were flaring, and that even though the baby's totally calm, and that means that the baby's still struggling in spite of what you might see. So we had to have, after that, we have to have difficult conversations because everybody's so happy and thinking, well, I did a home birth. And then we have to say, we feel that this would be a case for transfer. Yes, the baby can clear everything, but it would
Sometimes
be
they just need longer supportive care.
yeah.
Or to be watched more closely with monitors that we don't have at home.
Right. It would be smart to use technology at this point.
So it's not an emergency. It's more like this baby just needs to be watched with, more technology than we have in our bags right now.
Right.
For a long period
So,
of
yeah,
time.
I wanted just to address that because that's quite a common question. And if people are still concerned, I mean, I want to be very honest so that, because that's what, if you ever watch a movie, it's always the baby, so everybody thinks, babies, are like so dangerous when they're born. And I had a mom who, she was an actor, and she was pregnant throughout her whole, she was pregnant when she was doing a movie, and her birth went so beautifully, but she played a woman who gave birth, and there was all kinds of emergency because she was pregnant. What she played in the movie was totally what movies are for, because they are those like crisis, these are like, critical, controversial situations. That's what's being used. Births are being used for that. And in reality, she had such a beautiful birth. But sometimes it's hard to pass that, that mindset. And if for some reason you cannot overcome that fear, then really home birth, would not be right for you, because you need to feel safe all the time. And there are most of the time, once you develop your relationship with your midwives and you realize that we don't just use sage and like smoke the room and chant, and that we have all this equipment that tends to people tend to trust us. But if you're afraid, and you're afraid that it's hard to shake that image or that emergency, then we often have to, honestly say that's probably not for you.
Thank you, Kim. If it's okay with the midwives that are here, what I'd like to do is maybe look through my questions that have been submitted, and I see some hands are raised. If your hand is raised and you mean for it to be raised, just leave it raised, and we'll answer your questions. And many of these questions have already been answered just in the first 40 minutes of this presentation. So if one of the midwives wants to answer this is a question from Marin. If you're here, Marin, and if you have more questions about our answers, we can do our best. But the first question she has is, can I continue working with my OBGYN until I birth in June?
I'll take this one. This has been a big, we've had this discussion amongst the midwives, and people do come and say, money is not an issue. I'm going to use my insurance here and pay you cash. But really, this goes back to the culture of which the medical model of care works, and then the midwifery model of care, and then how we conduct business at home, so to speak. So if you're trying to, have prenatal care within these two systems that don't ever really sort of see eye to eye, it doesn't work when there's any sort of conflict. And most likely 99% of the time, if your doctor says you need an induction and we say you don't need an induction, because you're old and 35 or something like that, you're going to side with your doctor, because most people are more comfortable in an institutional setting, right? So you have to really be able to be ready to jump into the system that we provide at home, which is really a system created around you and what you need. So the short answer is no, you can't. Even if it's a cash paying situation, it makes it very complicated to make clinical decisions around how we care for you. So no.
Thank you, Noonie.
But that also, it's dual care. I think there's nowhere else in life that I could think of that you would consider seeing two people for the same thing that provide very similar services. Like you can see an acupuncture while you're pregnant, while you're seeing your midwife, but there's two different services. So that dual care, I think it really, you really have to sit with yourself and make a decision on which type of care you really want for this experience. And that's when you have to surrender and start working with that provider. Because if you are working with two providers that basically kind of provide the same thing with a little difference in it, you really are torn, and you're going back and forth. You haven't made a commitment to either one, so you're not trusting either one. So that's not a good headspace to go in to have a baby, because you're not picking someone that you're actually going to rely on and develop a real trusting relationship with, and vice versa for the provider. It wouldn't be right whether I was an OB or a midwife if someone was doing dual care, because I feel like you're not committed to either one. So there's not that trust. Trust goes back and forth. The provider needs to feel that you trust them, just as you need to feel that you trust your provider.
Thank you, Martine. Another question for anyone who wants to take it. How do I have to prepare my home for a home birth?
I'll take it. Let me think. You got a birth kit that's traditional. You get it around, in the last trimester. And what you need, you kind of turning your home into a birth center of sorts. You have a birthing ball or two. And you make sure you have a lot of food. What I do, we all are individual, we'll have our unique ways. What I do is ask the client to have a chin-up bar. That's very easy to buy. You probably buy it. It's probably like this purchase that you regret, but you have it somewhere in your storage. And so you just put it over so that you can hang on it. So. And then some people have questions about whether or not the place is going to be messy. And you can, so we have part of the birth kit, we're asking you to get chucks, those wee pads, so that you're, to try not to, most of the time it looks like nothing happened, but sometimes you can have a patch of blood on your carpet. So if you have a carpet that you really love, you should roll it up and put it out of the way. There's another thing people ask, which is, will the neighbors hear me? And this is New York City, so the answer is yes. But I've always found that, and this is what I say, that the neighbors, if you put a note under their door or in front of your door, we are having a baby, please forgive the sound, something like that. I said the opposite is going to happen. The people are going to get really excited that there's a baby being born. And we've had neighbors put cups on the wall to hear the baby being born. So what I'm trying to say is that you don't really bother your neighbors, because everyone gets giddy and childish when they know that a baby's being born. I wouldn't say it in advance, because people think about it and they get scared. But on that day, if some people had suggested, should I put a little champagne next to their door? I said, no, you don't really need to do that. You just can put a little note under their door if you want, for any of the neighbors that may hear you. Does anybody else can think of anything?
Can I share my screen for a sec?
Sure.
So I think, hold on. So I just put a little list together for what you get in your birth kit and supplies, because sometimes people would ask about their house being clean. Just remember, that's the baby's environment, whether they have a spick and span, everything's made out of glass and is in white, or that, they have, dust bunnies and, hairballs from the cat all over their house. That's their house, and that's the bacteria that their child will be colonized with. So usually we just have a birth kit. Every midwife usually has their own that has some supplies. And as far as cleaning, I said we are housekeeping, so no, your house will not be dirty when we leave. Um, and then I think sometimes it's always so it's a mystery about the supplies we bring. So when we naming them all, sometimes it sounds more intimidating, like we're really moving in with you, then we're not. So this is a picture of my trunk. So, you know, want to be picked up from the airport? I don't think so. So basically it's this bag, that would be the oxygen tank, and this bag. And then just one of this little bag that's in here, that's the Doppler bag. And so if everything goes well, you never really get to see everything in this bag. All you see is this. So 2 clamps and a scissor in there, the cord clamp, your emergency medicines, your methadone, your Pitocin, your herbs for bleeding or placenta that won't come out, the bulb that we usually give to the, you know, the 3-year-old child to play in the tub with, gauze, a syringe, you know, and really, this is really all that you ever really need. And
Thanks, Martine. That's so thorough.
Sorry, sometimes give talks and presentations. It just happened to be on my desktop. Now I have to try to figure out how to get it off.
Whipped it out. Yeah, you just push stop share. There you go. Thanks, Martine. That's great. I have another question here. We have lots of questions. We're going to get to them all, I swear. Does somebody want to talk about the treatment that the baby gets and what we handle after the birth, including breastfeeding?
Sure, I'll go.
Thanks.
Yeah, no problem. So after the baby is born, most of the time baby goes directly to skin. We're leaving baby there, really letting you have some uninterrupted time, letting baby do the breast crawl and initiate that first breastfeeding on its own. When it's time and it's appropriate, and depending on, you know, what the timing is, what is going on, we'll eventually deliver the placenta, cut the cord, and then after some time, it'll be time for us to take a really close look at baby. We do that initial look at baby, just making sure everything looks okay. We're listening to the baby's heartbeat usually right after birth. But then besides that, we're not really doing much as long as baby's making the transition well and not needing any extra support. And then when it's time, we'll do a full newborn exam. We're checking reflexes, we're checking anatomy. And then if the parents have elected to have it done, we'll give the vitamin K injection if they've elected for the injection. If they have chosen for the oral drops, then we'll get to that later. But we'll do the vitamin K at that time. Yeah, am I missing something? That's usually what happens at birth. So full set of vital signs, we can give the vitamin K, and we weigh the baby too.
We do a full newborn exam, head to toe, weigh and measure the baby. And I'll just add also that, of course, we provide lactation support. Different practices do that in different ways. If the midwife themselves doesn't come to give extra lactation visits, they have somebody on their team that comes to you to provide lactation support. And last but not least, I always like to mention that we do take care of the birth certificate and the Social Security card. So in case you had another baby in the hospital and you wondered, my mom's big question was, who does the footprints? So we have them, and my home birth midwife did them.
And we also have a screening that we do when we come back in the first visit. We do the newborn screen, the one that, you know, with the heel stick, where you, and that's given free by the Department of Health. So we do that, and we do that with your baby, you know, breastfeeding, so that, you know, we try to make that as calm and as, you know, that, you know, obviously it's a stick, so we try to talk to the baby and be gentle with that. So that's one. And the other one we do is something that's fairly new that got implemented in the last few years. We put a pulse ox. Basically, we shine a light on the baby's hand and the baby's foot, and that'll tell us if the baby has very mild heart condition that is not obvious, meaning the baby's color looks good, but there's something that needs, if we can early detect it, then because a lot of people grow up with these mild heart conditions that they don't know about, and so that would be one, that would be the thing that we want to see. So basically 2 tests. There's a third screening, which is a hearing test that we don't do. But that can be done at the pediatrician, and that's not a timely thing. It's not like you need to do that right away. So I wanted to add that on, Tanya.
Thank you. I think we got it. The other thing that we don't do that the hospital offers, I just thought of it, is I think pretty universally, none of us offer a hepatitis B vaccine, which is something that they offer in the hospital to babies. But if you are not positive for hepatitis B, then it is a perfectly fine vaccine to get at your pediatrician if that's what you would like to do, and your pediatrician can offer that to you. So I have the next, I see all your questions, guys. Thanks for putting them up there. They're great questions. Another question that we get very commonly that I think would be great if we could address is the question about cost, insurance coverage. What if your insurance doesn't cover home birth? What if you have Medicaid? These kinds of questions.
I can take this. So we are all considered to be out of network. I think just about everybody knows that. We all have a standard fee that ranges a little bit depending on practice to practice, but what we all do is we work with a biller who will walk you through the whole insurance process and give you an idea as to what your insurance will cover. But for the most part, none of us really talk money with our clients, because that goes back to building on the relationship of trust, and money can be tricky. So if you have any sort of questions about that, you just ask one of them, when you go to interview the midwife, you just ask to be in touch with the biller, and you can have a whole conversation with the biller before you even decide if you are going to come into our practice or not, because that can be a really big deciding factor for some people, that yes, they want to have a home birth, but they can't afford it at this time. Or their insurance isn't going to cover it, and maybe they're coming late into the pregnancy. So it also depends on what trimester, depending on your insurance. But we all allow you, for the most part, to chat with our biller and make because the money part is a deciding factor.
Thanks, Noonie. I should mention that there are many midwives who accept Medicaid as payment. Not all of them do, but many do. And I think that midwives work really hard to make it possible for people financially to have a home birth. And there are laws in place here in the state of New York that make it so that we will be covered. So for example, in some cases, if you tried to get a midwife in the hospital who was out of network and they were not covered, oftentimes they may cover it if it's a home birth midwife, because there are no in-network home birth midwives. So usually they have to give you what's called a gap exception. So there are, different scenarios. The main thing is this: don't call your insurance blindly and ask them about whether they cover home births. The first thing you should do is talk to a home birth midwife, talk to our billers, because our billers just bill for home birth all day long. So they really are experts in helping you get the information. But I would say that a lot of people don't know this, but I feel like we take care of a wide range of socioeconomic situations. And that is specifically because we're here in New York City and that's who lives here. So we're very happy to be able to be accessible to people. Okay, anybody else want to say something about payment and insurance? And I'll get to these questions that are here.
Yeah, there's something you should know too, that if you transfer later, we're less likely to get as much from your insurance.
Right.
Yeah, if you come soon, then we can get what we call a global fee, and most likely the payment is going to be a lot more than if you were transferring very late. So we're having obviously these issues right now where people are coming very late, and so finance is another thing that they have to take into consideration. The other thing I like to tell my clients is insurance will make you jump through hoops because that's how they operate. They will make you jump through hoops so that you give up. And so we ask our clients to be very proactive in calling and being a pain and just keep calling. And our billers are very good at giving scripts and of what to say, how to say it. And I like to say to my clients that the noisier you are, the bigger the checks we often see. That just happens to be the case. So we want you, because they don't pay us quite enough. They will pay at the drop of a hat. They will take your baby and put him under the blue light, even when in our care we would know that was not necessary, and then they'll charge you, way more than a home birth would cost just to do that to your baby. So hospitals has the system all set up, but because we're only 2% or 2.6% of the country, even though they are making so much more profit really from us, there are too few of us, and they kind of ignore us. So the advocacy, we ask our clients to be proactive in that, in making those phone calls, because we do see results when they are determined.
And I would just like to add that in my experience, overwhelmingly, people get excellent coverage. There are exceptions from time to time, but most of the time, what I find is that, they give us something, and it's not most people that have no coverage at all for their birth. So I hope that is helpful. Give us a call. Okay, I'm going to go through the questions that are here. So we'll come back to this inquiry later because it's your specific situation, and maybe that question will be answered. So Tiffany, hang tight. Let's see. Yes, we're being recorded. So Maya Hernandez has a question. RCOG recommends against water births during COVID times because they say health workers cannot protect themselves with proper gear in a water setting. Are you still allowing birth pools to be used at home births during this epidemic, or do you agree with RCOG? And I guess my question for Maya, if you're on here, would be, is this RCOG's recommendation for home birth or for institutional water births?
I don't think they specify. So I was just curious if it's something that you're thinking about, because I know birth pools are so popular during home births.
I mean, we home birth midwives have been talking quite extensively about the way that we are keeping our clients healthy right now to make sure that they don't have COVID when they are in labor. So I don't know if anybody wants to take it away from me and talk about the measures that we're putting in place, because we do know that the one thing that keeps people safe is staying home.
All right. So as far as the water, I mean, for me, the real reason, like I ask people to get a tub, or we have tubs that we pass around, is for the labor, really. I always find that the birth, when women want to have a water birth, that's a luxury, and great, we'll do it for them. But by the time your baby's crowning, the water doesn't serve that pain relief function. So that's why I suggest a water, I really recommend, and we pass these pools around. But so I myself, that's what I'm doing. I am, just to play it safe, we're still recommending the pool, but before before the baby's born, we get them out. Because until we know more, we just have to play it safe.
Yeah, there's a lot we don't know. That's part of the issue. Anybody else, Noonie or Shauna, do you have any other practices that you think are going to be in place?
I think going forward, what Kim said is most likely what we're going to end up doing until we know more, right?
Yeah, keeping in mind that while, most home births will have a tub available, most people don't give birth in the water. Even if they plan it, they get out. Mm-hmm. So it's not never. People have water births and it's fine, but it's not as many as I think some people think that every home birth baby is born in the water, and it's definitely not everyone, and it's not even most of them. Okay, so Burku has a question. Tanya, I have some clients who have been asking, how do I choose the right midwife? Well, I just want to say, and you guys can correct me if I'm wrong, we have the best home birth midwives in the country in this town. Like, I mean, like, we have amazing home birth midwives who are highly trained, highly educated. And obviously, because we're in New York, we have a volume of clients that we have been able to help. So everybody is pretty experienced. And because of that, I feel very confident recommending any of the home birth midwives that are in the collective with me.
I think it's a luxury that people actually get to speak with you before you work with them. Or oftentimes home birth midwives will actually have a consult with people or a long phone conversation or whatever combination. Whereas when you're choosing a GYN or an OB, there's none of that and people choose them. So, you know, like I totally agree with Tanya. It's all different personalities, but you're really basically the same service. So everyone chooses and picks differently. So sometimes it wind up being such a shop around kind of thing that I feel like the initial conversation, you know, if you click, you know, someone that you're really interested called you and they sounded really good. You're like, yeah, I'm gonna meet up with them. Then you might meet them, but I don't know if it's so necessary to meet, you know, 10 practices before you choose, because then I think there's some education when you go from practice to practice or meeting 1 or 2 practices and you will learn more, but then I think just makes the choice harder, because I think if you're seeking this care, most of our personalities fit that because we want to offer this kind of care. So I think shopping around a little bit, but I think it's pretty easy to hone in who you actually really click with. That's going to be in your house. You know, like I always said, I knew I was a home birth midwife when they had one toilet and she wouldn't get out of the tub. And I said, oh my God, I have to pee in front of somebody. So you actually figure out who you click with. I think pretty easy, you know?
Yeah. And just to add to that, if you are interviewing 5 midwives, by the time you get to the 5th midwife and you haven't felt like the other 4 midwives are, you know, bonding with you, you know, you might not bond with the rest of them, right? Because you're likely within a few interviews know who you like. And people tend, it's a human, you know, it's a very much a human care. So if you sit with a midwife, you're likely even, you know, sometimes it's like a love at first sight. So usually the person you interview first is going to be like, oh, you know, I like her. Because, you know, you just feel cared for, and people tend to like that. So just go with your gut, look at the website, look at our faces, and just decide, okay, I'm going to interview this or that person. And then just go from there. Because if, like I said, if you're interviewing 5 people, you might want to consider what is it that you're so afraid of.
I think it's a great point, Kim. I couldn't have said it better myself. And I think, you know, there are certainly, you know, I think websites that have lists for, you know, of questions for a home birth midwife. I don't even think that those are very good. I think, you know, I know for me, when I sit down with somebody who is interested in home birth, I always start out the conversation and I say, so what brought you to home birth? I just want to hear about them. And I just, you know, I think that knowing that we all bring Pitocin, we all bring a bag of stuff, you know, we're all licensed, we all have good outcomes, you know, we all delay cord clamping, we all do all of that. You know, whose personality do you click with that you're going to be spending an hour every month, and then every, you know, 2 weeks, and then every week until you have the baby? Who makes you feel like, yeah, I want to get together with this person or people and have a baby?
Yeah, the interviews, you know, people do come with a long list, and, you know, there is a limited time because it'll take a couple of hours to go through your list. But we're asking you because you're coming in, you know, with, you know, the trust is needed. So we're asking you to sit and chat with us. We're asking you to like meet with us, because you don't meet with doctors like that. So this is your unique opportunity to connect with your midwife, or, you know, connect and to sort of be a little vulnerable and to see if you know, bond. You know, that's how I feel about interviews. So, you know, if you still feel you need to look at that list, yeah, okay, you know, look at it, but usually you wouldn't have to.
Just kind of flows.
It kind of flows naturally.
Alana, if you're still here, I don't know, do you have your hand raised on purpose? And if you do, you can unmute yourself and talk to us and ask your question.
Sorry, I don't have my hand raised on purpose. I think that was from the poll.
Okay, I lowered you.
Okay,
But
thanks.
thank you for offering that your understanding for the RCOG recommendation is that it is only if the birthing person is positive for COVID-19. That's your understanding?
Yes, right before this, I was watching the evidence-based birth webinar where she covered this, and that is what I remember.
Oh, cool. Okay, we'll check out the RCOG recommendations. So that's great. We're learning right now too, as you know, in the face of all of this. So thanks, Alana.
Thank you.
Okay, let's see. Great. Caroline wants to know, how late in the pregnancy will you take a new client? Noonie, it's you.
It's Noonie.
Because I keep picking up people's phone calls for some reason, because I know some of my colleagues are not doing that anymore, but I just have been, I think today I'm going to stop because it was too much before breakfast. My husband he was like, turn your phone off. I think it really depends. I think in the time of COVID, we have decided to not be taking these late transfers for a number of reasons. And I'm sure you've all read the collective letter that we put out last week, which really explains that the fear of having your baby in a hospital, especially if you're calling and you're saying, I've been with this practice at this hospital, you know, that has a high C-section rate, a high induction rate. I don't have a doula. I've never taken childbirth education, but I really want a home birth, and I'm due tomorrow, and it's my first baby, and what's a doula? And, you know.
Can I have an epidural at home?
Yeah, and so these are really, yes, and these are the questions we've been getting, and to play all of that catch up is extremely unsafe. But I think if we, so as a collective, we really have decided to not be taking these last minute transfers. And if you'd like, we can speak more about it, but I really recommend that you read through our letter. But I think in the real world, I think it really, it goes case by case, right? I think if somebody comes in and maybe it was an insurance thing, or maybe they moved, or maybe they didn't know it was an option, they didn't do their research. It really depends on the person. And I think they have to be a really good candidate. They have to also be convincing and ready to jump in and do the work. And we also have to connect on a level that is like, yes, you know, I'm going to trust this person to do this work, but it's not going to happen all the time, and it's going to be case by case. So I don't know if anybody else wants to add to that, but I mean, I think in the real world, the latest I've taken someone was.
You can tell the truth, Noonie.
No, I'm trying to. Okay, and
we've all done it.
Not 40 weeks, but I think 34 weeks was the latest I ever took somebody. But
really? Come on.
I'm talking in normal terms.
What's your latest?
Shauna, did you add to that?
I took somebody the day before their due date. Yeah. So,
yeah, I took somebody later once.
But she
wasn't a COVID person.
No, she wasn't. She had been breech the week before, and she went for a version, and they were able to turn her baby to head down, and they still wanted her. They weren't going to let her leave the hospital. They wanted her to stay and be induced, and she advocated for herself to leave because she was like, my baby's now head down and there's nothing wrong and I want to leave. And they were basically using fear tactics to try to keep her to stay. And so she called me with a story and was willing to do the work that she needed to do to get ready for a birth at home. And she worked really diligently and got a doula and got her pool, and it was amazing. So, and she had a beautiful birth at home at 42 weeks.
Woohoo!
So, yeah.
Sure, I really like her. So I'm really glad you brought her up because
I
she
know.
has such a personality. You know, I would
Yeah.
have taken her, and I was jealous that I was I was full, but when you got to deliver her, I was like,
Yeah.
oh, I really did want
Yeah.
to
It was
get her
amazing.
because
So
we're talking
yeah.
about personalities, right?
Yeah. Yeah. In a case by case basis. So I don't, it'd be hard for me to say, oh, I have to cut, no one past 37 weeks because things happen after 37 weeks. And so I think it's always worth reaching out if there's somebody who's later in the pregnancy and there's been some circumstance and they're looking for a home birth. It's just less likely, but it's not impossible.
Yeah, and
I
knowing
guess
that
I would
everybody
say.
is really excellent. I mean, I would always suggest if somebody was deeply committed to doing that, to just call down the list and see who will take your
Yeah.
call.
Yeah, exactly.
They're wonderful, and I've gone to people in labor, and I know I'm not alone in that.
Okay, so you beat me on that one.
I showed up and I was like, oh, I see head. Great.
Okay.
I've done that, but we were on the phone call a lot. She was very clear, and we clicked, and she hadn't made up her mind. And then when she got into labor, she called me. She says, I've made up my mind. And I was like, okay.
But I should say, this person that I went to in labor, we also we kind of had a relationship. I gotten to know her over time, and
Right.
wasn't a complete stranger. So
complete stranger, I don't think any of us would do that, honestly.
No, we don't do that. But many people, pee on a stick and call us right away. And sometimes we're booked months and months in advance. So it just sort of depends on what's going on. So, okay. So Quiva, is that how you say your name?
Oh my God, amazing. Well pronounced. Thank you so much.
You're welcome. I know my Irish names. I get a medal. Okay. What's your question?
So I'm one of these, I guess, famous COVID ladies, I guess you could say. I'm 5 weeks to due date. I would have been very well disposed to a home birth anyway, and it's been lovely to listen to all of you. My siblings were all born in the room beside me. My mother had 3 home births after me. And I mean, I guess I find myself in the situation now where I'm 5 weeks to due date, and I've had this call that partners aren't permitted. And I'm seriously considering moving to a home birth if anyone will have me. I don't know if it's too late for you guys, and I guess it speaks to the last question. And I also, I'm massively respectful of your need to protect yourself and make sure it's right for you. But I'm just wondering if you have any advice for women who find themselves in my situation. I mean, I was already borderline on the hospital care here anyway. It's my second child, and I delivered in the care of midwives in a hospital setting in Ireland with no intervention. And I was nervous about the hospital approach here. And this just adds to it. So I'm just in the market for advice. I don't know if I should just plow on and focus on getting through it in the hospital, or if I should really look hard for alternatives. So any advice you can give will be gratefully received. Thank you.
You're welcome. I'm really glad that you're here. We can't wait to talk to you. Everybody's just can't wait to say something. I can see that. So I just want to say that you don't have to birth alone in the hospital. I don't know what you're going to do, but you don't have to do that. So that's the first thing I want to say. But if somebody else wants to speak first, they certainly can.
I know that the last I heard, Brooklyn Birth Center are taking clients, and they are allowing, and I think they're allowing non-symptomatic partners. I believe even doulas to come in. You just have to do their protocols. They have good protocols on what you have to wear and your clothes and all of that. But that's would be the first place I look if your reason for wanting to change is because of the partner situation. Right?
There are also just 4 hospitals that are coming to mind right now that, and 2 of them that I'm thinking of that I know for sure will be allowing partners into the room. That will not change according to the mayor, and that is any New York City public hospital. So that's the midwifery services at Metropolitan Hospital or at North Central Bronx Hospital. And both of those places are hospitals that we transfer our home birth clients to if we need to go in, and the midwifery service there may feel a little bit more like the midwifery service in Ireland because they do have midwives that are really running the floor there, and the style of care is very different from an OB. So those are 2 excellent options, as well as, you know, more on the OB sides of things would be if you could get a practice at Lenox Hill Hospital or NYU Hospital. They're more high-risk hospitals if you have a high-risk reason to be there, but they are still allowing partners in. I think the Brooklyn Birthing Center, I think, is the only one that's letting a doula and a partner in.
Just to mention, in case there are any other women in my situation on the call, I spoke to both Bellevue and Metropolitan today, and they said that they couldn't guarantee that they were going to maintain that position.
Right, everything's changing daily.
Everything's changing. It's coming. I mean, this is what the mayor said yesterday.
Yeah.
So the mayor said that they're going to be holding on to that, but it is very, very tricky.
Yeah.
I think the Brooklyn Birthing Center plans on staying that way, though.
And should I follow up directly with, if I, like, because I think I am, safe to say, interested in pursuing a home birth, should I just phone you guys individually?
Yeah, you should just call down the list and see who has room. And, you know, a lot of people you're probably going to get a lot of no. But I think what will happen is that, keep in mind that what's also happening to all of the home birth midwives is that we all have clients who have decided to go back to Kansas to have babies. You know, they've decided that they're going to go back to Indiana home, and that's where we're upstate, and hire a midwife up there. And then, of course, people do risk out of home birth. So people will have openings as time goes on. It's just, if somebody is full right now, in 2 weeks, they might have an opening. So you can always ask to be placed on a waiting list, and to be contacted if anything opens up. And if anybody who's on this call right now has room, make yourself known.
Thank you so much. Thank you.
You're very welcome. My pleasure. But you don't have to give birth alone.
Thank you.
You're welcome. Okay, hold on. I have new messages.
I just wanted to add that Joyce is adding that the Danbury Birth Center, which is, I mean, it's in Connecticut, but if you really want your partner and your doula there, you have to get in a car and go for care. The Danbury Birth Center is still allowing doulas and partners. And Lonnie Morris in New Jersey, she's not taking April due dates, but she is taking May and later. And she is a private practice in the hospital.
I heard it was June and later.
Doctor, yes.
A recent. Oh, okay, good. So you have more recent information than I do. Good.
Well, you know, day to day.
It's worth a call.
Call, yes, for sure.
Winnie and I both did she was our preceptor. She's a great midwife, and they have a great practice over there.
I'll just spell her name down there so you guys can have it.
Yeah, it's childbirthcenter.net. I'll write that. Maybe, is another option the Birth Center of New Jersey in Union. Is that the birth center, Nubia, that that Lonnie works with?
Yes.
So I think that would be an option. Oh, I only sent it to her. Hold on. Zoe, Tanya, can you clarify what you mean by not having to give birth alone? Yes, I can. I mean giving birth with a companion of your choice. And if that means that you are planning to birth in a hospital that won't let you do that, to each their own, but you can choose to go somewhere else. You can. There are places where they're allowing people to bring their partners. There are many places. Mount Sinai and New York Presbyterian don't own every hospital in New York City. And of course there are I think all of the hospitals in New Jersey are, right, New Jersey midwives and Avalon midwives. Morristown Hospital, I think, was saying no partners, and they rolled it back the very same day and now are allowing partners again. So certainly many things in New Jersey, and New Jersey is not far. I live on the Upper West Side, and I did my training in New Jersey, and it took me 33 minutes to drive to the hospital every time I did. So totally worth the price of a rental car if you need one. So that's another good choice. Okay, let me see if there's anybody else I missed. Let's see. I want to see if there's any other hands raised.
Can I just clarify? I just to make sure that it doesn't sound like we're saying just to, when you're in labor, just go to the place of your choosing. I mean, it would be lovely if you found a practitioner from that place and started having care there and switched completely. Or at least if you did show up that way, that you actually have your complete medical records. And a lot of people are doing electronic medical records, so at least you'll have your actual records from your pregnancy.
Yeah. The other thing I want to say is that the reason, I mean, one of the reasons they're asking you not to have, they're not allowing visitors is because there aren't enough protective gear to pass around. That's one reason, right? If you're trying to do isolation or, like containment, then if you have protective equipment, that becomes less of an issue. I don't know what's going to happen. We're all in a state of frenzy for equipment. I mean, us home birth midwives we're helping each other, so we have it, but the hospitals are having a problem. So I know you guys are, you're pregnant, and it's difficult to think, at multiple levels right now. But if you know someone at the city level, if you're pushing, I mean, I'm expecting an avalanche of equipment to come soon, the way they keep promising and promising. So I think this could change if you pushed the city and you went up higher to try to advocate for getting equipment. If they have protective equipment, that solves the problem. So, it's sad because one of the reasons why you can't have people is because they cannot give out extra to the doulas or the partners. So knowing that, you can try to see if you can, the doulas, some doulas are here, and I've said this ad nauseum, but I will say it again. Try to advocate at that level to see if that can help, because if you win on that level, then a lot of the suffering will, it will resolve. This will resolve in terms of like the need, the partner thing and the doula thing, right?
Right. Because the pandemic is real, and this virus is deadly. And just not being able to limit the number of people I totally get it, in a small space. But some hospitals also, the issue for some may be there are no single private postpartum rooms. At NCB, North Central Bronx, and at Metropolitan, 2 city hospitals, they do have private postpartum rooms. Because I know that was a concern for some people, so that would be 4 people in the room. You, your partner, her and her partner. And that does, and the 2 babies. So that does increase that there are more people into a crowded space that weren't quarantined at home before you went into labor together. So that part, I get that part, but having, luckily in all hospitals here in the city, you do have your own private room for the labor, and hopefully you can have a private postpartum room.
Yes, and the city hospitals, North Central Bronx and Metropolitan, as Martine said, do offer private postpartum rooms at no extra charge.
And Woodhull.
And Woodhull, but I heard on the call the other day that Woodhull they have some sick midwives there, and they're having a little trouble. So probably they're a little bit more
understaffed.
Crowded. Yeah, understaffed right now. So that's that. And Kim, I don't know, since you brought it up, and we have a few more minutes here, and you and I both have been speaking with our contacts at Cornell, at New York Presbyterian.
Yes.
They mentioned that if they receive the protective equipment, that they're going to be allowing partners in?
Yes, that's the idea. I mean, it all comes down to getting equipment. So the other thing is, the thing that you have to know, and a lot of you may have heard, is that there are talks of separating mom and baby if mom is COVID positive, right? But it also depends on the hospital. What we've heard, the last we've heard, and New York Presbyterian, they're not doing that. That Dr. Sylvester, that's where he's at, right? NYP, yeah. And he says they are not doing it. They are not separating moms and babies, even if moms have it, which is logical because, separation is bad for the baby anyway. And then the baby somewhere, the baby, is not with the mother. Breastfeeding and getting all the all the good stuff and all the protective thing that's coming out the breast milk is actually really good. So, and of course, nobody wants to be separated from your baby. So that's another thing that I'm sorry to bring up, but that's also a really big deal right now. So you might also want to ask those kind of questions if you're. But it's crazy. I'm hearing that they're actually not testing, or when they test, the test that comes back. By the time the test comes back, I mean, if it's a 4-day test, you would have left the hospital by then. So I'm confused. Every day things are changing. So
we had a client that was tested at NYP, and she got same-day results.
Yeah. So at Mount Sinai, what they're doing, which I know because I used to work there, they have an 8-hour turnaround time for this particular test. And same with Sarah Lawrence Hospital, two very random hospitals. But what they're doing is they're testing everyone, despite symptoms or not. And if you are positive, they follow the flu precautions where they are not separating mom and baby, but you have to wear a mask when you're doing skin to skin and breastfeeding, and your baby needs to remain in isolate 6 feet from you, but you still can continue to breastfeed. You just have to wear a mask around your baby. But I have yet to hear, and if any of the doulas have heard of anything going on, because you guys know what happens in the hospitals too. I'm not sure what happens when someone is COVID positive and symptomatic, because lots of people, I mean, we know all the celebrities right now have COVID positive tests with no symptoms. So I'm not really sure what happens if you are positive with symptoms, what happens to your baby at that point.
And I just want to add that my heart goes out to every pregnant lady on this call or that's not on this call at this time. But something else to think about is the discharge that they're doing. Like I know NCB is really trying to get people out in 24 hours. And I haven't heard that from some other hospitals. And I think this is a lot to take on when you're term. So not that having a lot of information is good, but being bombarded with all the changes and having to look for it yourself. So my suggestion is if you did have a doula, they have a great network on social media of keeping abreast of what's going on and kind of tuning into that. So, if you want to tune out and someone is keeping updated for you, your partner, your doula, or someone else, or if you function better by knowing day by day, minute by minute, because it changes, hour by hour, it can be really overwhelming. So make sure you take care of yourselves and you step away a little bit too and have someone monitor the situation. And, when you start feeling like you break your water, you start going to labor, then you can get update of what's going on right now today. And maybe your head won't spin as much, I hope.
Sending. You have one more question?
No.
You want to unmute yourself? I saw your hand go back up.
No, I was throwing a kiss.
Was that me? Sorry.
I was throwing a kiss to all
Priva. Yeah.
Oh, sorry. I just wanted to say, in case it was helpful to anybody, that I also asked this question to Mount Sinai, to NYU Langone, and to Metropolitan about the separation of mothers with COVID. They all confirmed that they were separating.
Good.
They were yes or were not?
They were, yes. Which I was
reading.
Yeah, that's what I thought. Yeah.
Because it's against the WHO guidelines, but they're all doing it.
Wow.
Yeah, CDC, it's the problem. So WHO says not to separate. CDC says to separate for 14 days.
Yeah.
So just for the doulas that are on, thanks for adding that. For the doulas that are on, just know that your clients are going to be facing all kinds of unknowns. Okay, well, friends, we're at the end of our presentation. I want to take this opportunity to thank Kim and Nuranisa and Martine and Shauna and all of you for coming. You have my email address now if you have any questions. I want to thank all the doulas that tuned in. I see there's some other midwives here. Nubia's here, and everybody who was here. And just to say that we're probably going to do this again as this unfolds. In fact, I think we're probably coming on every Wednesday for a little while. So we will be, if you haven't already, oh, thanks, Jessica. We love you too. If you haven't already followed us on Facebook and Instagram, please do so. It's NYC Homebirth Midwives, or NYC Homebirth, I think is the IG handle. We are going to be
the Facebook is NY Homebirth Midwives. NYC Homebirth Midwives. That's our Facebook.
Yes, NYC Homebirth Midwives. And then, of course, at our website, nyhomebirth.com, we'll have the weekly buttons where you can register for these talks if you're interested in talking more about childbirth, about home birth, and about the midwife's perspective on what's going on. We're very happy to share it with you directly, and it feels so good to have an audience. So please tell your friends and even maybe your enemies about us, and we would be very happy to have them join us. Feel free to reach out with any questions. All the best to you all for safe and healthy births. Signing off.
Bye.
Bye. Bye, guys. Thanks, guys. Quiva, I'm going to email you. You're welcome. Hi, Gabrielle. Nice to see you. Hey, guys. Hi, Maya. Hi, Mila. Look at all these friends. Okay, we're leaving. I'm ending the meeting. Bye, guys.